Our previous speakers have, I think, very clearly demonstrated how the use of data can help us improve services and can help us improve practice with the development of decision aids. Our other speakers, I think, have also very succinctly highlighted how the use of information services can help us identify problems and gaps in our service delivery and our service utilisation. My talk's a little bit different because I'm going to talk about how information systems can be used in education, and in this instance specifically medical education. I'm actually from Sydney West Translational Cancer Research Centre, not Southwest. I'll just make that point. Yeah, and we are nearly getting there. But essentially, any of you who are involved, particularly in health education, I'm sure will be aware of how difficult it is to demonstrate how our use of education or information actually makes any change in practice. We can certainly demonstrate that we change people's knowledge. Sometimes, if we're lucky, we can demonstrate changes in skills or confidence, but changes in clinician behaviour or practice are much harder to demonstrate, and that's why I guess medical education, I think, is an incredibly hard gig. But I am going to talk to you about a new... Oh, here we are, voila, thank you. So this is the development of a QStream. It's called QStream. It used to be referred to as spaced education, and it's on how we developed a program in relation to ovarian cancer for medical and gynaecological oncologists. So this is our team, and I'd like to acknowledge the hard work of all of those people from 3 sites. The sites involved in this particular study were Westmead, Royal Prince Alfred Hospital and Prince of Wales. So I'm sure there's been quite a considerable amount of coverage in the media around ovarian cancer in the last year particularly, and a lot of it's around the recent sort of breakthroughs, I guess, in recognising germline mutations in BRCA or BRCA1 and BRCA2. Now, the interesting thing, I suppose what we know about BRCA is that we know that if you've got a germline mutation in BRCA1, your risk of developing ovarian cancer by the age of 70 is 40%. If you have a germline mutation in BRCA2, your cumulative risk of developing ovarian cancer, pardon me, by the time you're 70 is 20%. At the same time, while that highlights the risk of having BRCA mutation, germline mutation, at the same time there's been some recent studies done that demonstrate that if you have an ovarian cancer in relation to a BRCA mutation, it can be associated with longer survival, and certainly if you have relapses or recurrences, it can be associated with more favourable responses to platinum-based chemotherapy. So that provides us with a strong rationale for going out there, I guess, and disseminating this new information. And the EverQ guidelines for genetic testing or referral for genetic counselling and testing were updated in 2012, and essentially, and I should say, by the way, that when I talk about ovarian cancer in this context, I'm actually talking about fallopian tube, ovarian and primary peritoneal cancers. So the updated guidelines essentially are that anyone with those sorts of invasive cancers, non-mucinous, age less than or equal to 70 should be referred for genetic counselling consideration of testing. So that is a change because in the past we had a lower age. So we had this new information. We were keen to disseminate it. Doctors are very busy people. We know that guidelines alone don't always cut it because often guidelines sit on shelves and rarely get consulted. And we know, as I mentioned previously, that changing people's knowledge anyway, running education programs, just changing their knowledge does not change behaviour. And I think there's very strong evidence of that in relation to smoking, for instance. We know that we can change people's knowledge about the effects of smoking, much harder to change the behaviour. Perhaps sometimes the more we're advertising that, we're probably just compounding their guilt and grief. So we were looking for a new way of disseminating these updated guidelines. We looked at, QStream babbling away. QStream was formerly referred to as spaced education. It was developed at Harvard University. It's based on the psychological finding that when you repeat information at particular spaced intervals, that it results in better learning and better retention of the knowledge. So what QStream is, it's case-based, multiple choice. You provide short cases, multiple choice questions and answers, and it can be delivered via email, which means that clinicians and busy doctors could actually access it on their phones, on their iPhones, via their email systems. So it has the potential to reach large numbers. Unlike Blackboard and other learning platforms, it doesn't require so much logging in, and it's very handy. So we developed a QStream program, on this, and that's what QStream looks like. So you can see there, that's how it comes up. There's a question. In this particular case, the respondent answered incorrectly. When you answer incorrectly, you get links, take-home messages, links, and then this question is repeated. If you answer incorrectly, it's repeated again at particular spacings. I should say that there's still more work needs to be done around identifying what are the optimal spacings, and in its pure form with QStream, even when you answer the question correctly, it gets repeated. So the idea is repeating the question short, sharp, over particular spaced intervals. So that's what we did. You can see there our study aims. We were particularly interested in the utility of this program, where the clinicians found it user-friendly because they are very busy people. And we were also keen to look at whether it impacted on their referral patterns. Again, what we were trying to do there was glean whether there was any impact on behaviour. So we actually ran it with 2 intervention and 1 control sites, and we looked at the rates of referral for genetic assessment and counselling and perhaps testing in 3 hospitals over a 12-month period. So it's quasi-experimental design. The qualitative aspects of that were semi-structured interviews and content analysis. And in terms of looking at the impact on referral rates, we are referring to KinTrack data, where we can compare the number of women diagnosed with the number referred pre and post the course. It's not ideal, because we can't always link the participant with the referral, but it was an attempt to see if we didn't just change knowledge, but if we also had some impact on practice. We had 29 clinicians enrol. Of that number, 21 actually commenced, and 17 completed all aspects. So that's, anyone involved in medical education will know that attrition is usually high, particularly in online programs. Attrition rates are very high. We actually felt quite happy with that 81% of our participants completed all the aspects. You can see it was largely here targeted at medical oncologists and gynaecologists, specialists and fellows, though we did have 2 nurses. When we conducted the thematic analysis of the interview findings, 3 broad themes emerged. We looked at the knowledge change, the impact on knowledge, the curriculum and format, whether it was user-friendly, the utility, the accessibility, and we're still continuing to look at changes in referral patterns via KinTrack, but we also asked our clinicians about that anecdotally. Here's just a selection of quotes. One of the things that's very interesting about this program is that doctors can be a very challenging cohort in terms of education, but they really loved it. This program, the QStream, just seemed easy. So many reported to us that it's really difficult when you work 12 hours a day or longer to go home and be expected to consult guidelines or to, look at education. But this was short, sharp. The email arrives. They can access it readily. It's a multiple choice question. It does get repeated, so obviously sometimes that can be annoying to some participants, but by and large most of our participants were really very happy with how this program ran, and particularly in terms of their schedule. And you can see that the second quote there indicates that, it does help learning retention, and anecdotally we have some reports of how it's actually impacting, that they would now refer more women than they would have previously for consideration of counselling and testing. But we hope to verify that when we look at the KinTrack data in November, which will be 12 months after the program. So there were several limitations around this program. The small number of participants obviously precludes any statistical analysis, and as I said, no formal CME points, which may have contributed to the attrition, but still by and large I think 19% attrition rate is fairly good for an online program. But I refer you back to that challenge, all of us involved in education. One of the good things about QStream is that it has had a number of randomised controlled trials conducted on it. I think there's something like 12 RCTs. These RCTs have demonstrated changes in clinician behaviour, changes in patient behaviour, and certainly changes in knowledge and skills. So one of the reasons we chose this particular platform is that it does have a considerable body of evidence. There is still some work to do around identifying the key spacing situations that result in the best outcomes, and we're continuing to use this program. We're about to conduct another QStream program looking at adverse events for oncology registrars, and that's going to be between Westmead and some hospitals in America, I believe, and Nepean. I think we've got some other hospitals involved too. So overall, this is a very user-friendly platform when you're working with time-poor clinicians. It was well acceptable. I think, though, at the same time, the science of implementation or improvement science, implementation science, would certainly suggest that one technique alone is unlikely to result in behaviour change, so it would be important to supplement QStream with other implementation approaches. And the science of implementation also suggests that one of the most powerful techniques for changing clinician behaviour is audit and feedback. And I think that touches on some of our former speakers this morning too, because clearly clinicians, it's a very strong behaviour change incentive when you can actually see the data in front of you. Very often we don't have good systems of data collection. It's not always possible to see, for instance, treatment outcomes for people in real time, but we do know that audit and feedback is a really powerful tool. So we would like to supplement programs like QStream with other behaviour change approaches. I think that's an important thing to do when you work in education, is recognise that knowledge alone, knowledge change alone, is not going to change the system. It may change people's knowledge, but it's certainly very unlikely alone to change practice or behaviour. So hopefully that might have inspired some of you who are involved in medical education or health education to have a think about that when we run programs like QStream, we've got some nice snazzy platforms and approaches, but we still need, you know, to conquer that hoary chestnut at the bottom, which is how do you actually change behaviour, not just knowledge. Thank you. That's, I think I finished a little early.